I'm going to talk about cluster headaches, a particularly severe form of headache. If you have these or know someone who does, then this is something worth watching, both for the understanding of these headaches, but also for the bigger picture that this story will focus on. It's the middle of the night. A man is lying flat on his living room floor. He's there because he has sciatica and a hard floor is the only thing that makes his back bearable. He has an oxygen mask on his face connected to a high-flow tank because he's in the middle of a cluster headache attack. He has a vagus nerve stimulator pressed to his neck to try to interrupt it. And pinning him gently but firmly to the floor, asleep on his chest, entirely unbothered, is a 3.5 kilogram baby. Now, on paper, he was functioning, seeing patients during the day, helping at home. That was my Tuesday. Wednesday, Thursday, Friday, you get the idea. I want to tell you how I got there, what I learned from it, and why I think it might actually change the way you think about whatever it is you're dealing with. And I hope you'll watch till the end. I'm Dr. Michael. I'm a family doctor. I trained in the UK and over the years I've practiced in many countries. I've been doing this for close to 30 years. In 2017, I started having a pain on one side of my head that I genuinely didn't recognize. By that point, I'd worked in surgery, emergency medicine, general practice. I'd been a ship's doctor. I'd seen most of what bodies can do to people. And this wasn't any of it. It felt like someone had put one side of my head in a vice and it just kept tightening. Always the same side, no warning, no build-up, and within minutes, completely brutal. And it came at exactly the same time every day, and often also at 2 a.m., 4 a.m., like a clock that was turned on and which couldn't be switched off. Now, I went to a neurologist, I got an MRI, got a diagnosis, and I accepted it because that's what you do when you're in pain and someone hands you a label. You just want the story to be over. The diagnosis at the time was trigeminal neuralgia, one of the most painful conditions in medicine, known for sharp electric bolt-like pain in the face. Extreme pain, yes. But as the weeks went on, something didn't fit. Trigeminal neuralgia doesn't arrive on a schedule, and mine did. Every day, often in the middle of the night at 2 a.m. and more times afterwards, attacks where you just cannot be still. You pace, you rock, because lying down makes it worse. Pain that left me completely non-functional for hours. Now that pattern, one-sided, centered around the eye, clockwork timing, worse at night, coming in bouts that last weeks, that's a cluster headache. And they're sometimes called suicide headaches. That name is not an exaggeration, widely considered one of the most severe pain conditions in medicine. And here I was, a doctor, not quite with a diagnosis, and months in. I'll do a full episode at some point on cluster headaches, what they exactly look like, what actually works, how to push for the right diagnosis if you think this might be you. But for now, the cluster headache is the vehicle of this video and not the destination. Once I had the right diagnosis, I was offered various medications, including anti-epileptic medicines, triptans, which are also used for migraines, as well as some very strong painkillers. But I said no. Call me stubborn. Doctors often don't make for the easiest patients, partly for reasons of not wanting to be on long-term daily medication with likely side effects, and partly for philosophical reasons. I wanted to understand what was causing the problem in the first place, rather than to just treat it symptomatically. I started trying to understand what was driving it, not just manage the attacks as they came. And over the following years, I built up a picture slowly. One of the early things that told me something useful was intravenous magnesium, given in a fully equipped clinic setting. And within seconds of an infusion, the pain didn't just decrease, it changed character. It became almost warm, neutral. And that told me something important, that this system could be modulated very rapidly, which meant it wasn't something completely fixed. It was something that was doing something in itself and could be altered. And things that are doing something can be persuaded to do something else. I'd been asking until then, which treatment will stop the pain? And the question I should have been asking was, which system is producing this pattern? The clockwork timing pointed to the hypothalamus, which is a deep brain structure which governs the circadian rhythm and a whole range of autonomic and automatic and hormonal functions. The location and severity pointed to the trigeminal nerve, caught in a loop that it couldn't exit from. The repetition, the way in which it sustained itself, the way it had its own internal rhythm, suggested not a broken part, but a circuit, a pattern, and patterns can be interrupted. Now, by 2023, our first child was born. The cluster came back. I also had sciatica at the time, which felt like unnecessary editorializing by my nervous system. And that's how I ended up in the scene I described at the beginning, on the floor, mask on, stimulator in hand, baby on chest. That was me managing. That was the equilibrium. And then when our baby was about 3 months old, even that broke. I was using the vagus nerve stimulator one night, a real medical device used in consultation with a neurologist, not something I just ordered off the internet in the middle of the night. The advice was to turn it up to the highest level that I could tolerate. So I did. And what followed made every previous attack look considerate. My neck locked completely. I couldn't move my head. I remember trying to cry and finding it was actually too painful to do that properly either. We called an ambulance. I ended up in the emergency department on high flow oxygen and with intravenous magnesium for hours before it finally started to ease completely. I've never seriously considered ending my life, but after that night I understood very clearly why some people with cluster headaches do. One night was enough to show me exactly how thin that line can be. And here's the thing I keep coming back to. I was doing everything right: correct diagnosis, evidence-based device, medical supervision, 7 years of hard-won understanding of my condition, and still I had the worst night of my life because I still hadn't asked all the right questions. Later in 2024, our second child was born. The cluster returned, and this time it had already been running for months with no sign of stopping. By this point, I'd reviewed more of the literature, spoken to colleagues, and we decided to try something I hadn't used before: low-dose intravenous ketamine, administered under medical supervision in a proper clinical setting. Now, ketamine has a certain reputation. It's been an anesthetic since the 1960s. It had a colourful life outside of medicine, and after nearly a decade of building a sophisticated understanding of hypothalamic circuits and trigeminal loops and autonomic modulation, the thing that was finally interrupted the pattern was essentially a drug that most people associate with either veterinary surgery or a very different kind of Tuesday night than the one that I had. But here's why it makes sense. Ketamine works on the NMDA receptor, a key part of how the nervous system regulates pain signaling and synaptic plasticity. The thinking is that it can briefly open a window in a stuck pain circuit, a moment of neurological flexibility in a system that has locked itself into a loop. Now, combined with the vagus nerve stimulator used at the right level, not the level that locked my neck, I want to be clear about that, the cluster that had been running for months stopped abruptly, almost immediately. The same thing happened in 2026 when the cluster returned. Same combination, same result. Pattern gone rapidly, in a way that I hadn't seen with anything else across nearly a decade of trying. Now, I'm not going to tell you I had cracked it. I haven't. Cluster headaches can go into remission on their own. A sample size of 1, even a very motivated and medically trained 1, tells you almost nothing about causation. But twice, reproducibly, in a condition that had been running my life for years, that's at least an interesting conversation to be having with a neurologist. I should probably explain at this point why I think about medicine the way I do. I came to it almost entirely by accident. At 16, a friend told me he was going to medical school and asked if I wanted to come. And I asked what would happen if I didn't like it. He said I could leave and do something else, pretty much anything. So I went. I spent the next decade after qualifying trying to take him up on that. Surgery, emergency medicine, ships, entrepreneurial detours, a lot of traveling. It took me 10 years to settle into general practice when most colleagues manage it in 4. But each thing I did added something. The clinical variety, the different context, the maturation that comes from doing medicine in genuinely difficult circumstances. It built a way of thinking that I don't think I could have got any other way. Now, I didn't plan any of this. I lived in a kind of blissful naivete for most of it, half convinced that I'd eventually end up doing something else entirely. But medicine just kept winning. I want to be careful at this point because this is YouTube and nuance doesn't always survive the journey. I'm not saying that you should refuse standard treatment at all. The evidence-based options for cluster headache are very real. They work for many people and they are the right starting point. I made an unusual choice in an unusual context with access that most patients simply don't have. Don't copy it. I'm not saying I found something that the field hasn't found. There are serious researchers doing serious work on this. What I am saying is that medicine, when it's tired, rushed, under-resourced, which is most of the time, defaults to symptom suppression. Take this, reduce that, come back if it gets worse. And sometimes that's exactly right. Sometimes it's all that's available. But for many chronic problems, recurring problems, things that don't resolve, stopping at symptom control leaves people without a story, without any framework for why things get better or worse, why 1 week is manageable and the next isn't, what they can actually influence beyond waiting for the next flare and taking the next pill. And that's disempowering. And I think that we can usually do better. Looking back, this experience changed how I practiced medicine more than almost anything in my training, because I had been that patient, sitting in front of colleagues I respected in a system I broadly trusted, with a condition that nobody was quite set up to think about as a system rather than as a symptom that needed to be put down, as it were. And I understood from the inside what it feels like to be handed a label and a prescription and still have no real idea what is actually happening to you. If you're dealing with something that feels stuck, chronic pain, fatigue, symptoms that come and go without obvious reason, I'm not going to hand you a formula. I don't have one. What I want to leave you with is a slightly different question to bring to your doctor. Not just what helps, but what is actually driving this? What makes it worse? What makes it stable? Which interventions change the system and not just the moment? You may not find a complete answer. I haven't. But you can usually find some leverage, and sometimes the shift from just reacting to a condition to actually understanding it, even partially, even imperfectly, is what gives you a meaningful amount of your life back. And that's what this channel is for. This is The Accidental Doctor, where we look at uncommon sense medicine. Thanks for watching. Stay well. Ciao for now.